Hello, everybody. It's Dr. T here, coming to you for another rapid fire Q&A. Before I get going, I need your advice. So, what do you reckon? Headscarf. So, this one I haven't prepared properly, but headscarf, something like this, or tied at the back, or no headscarf. What do you think? I need your thoughts about whether it's time for me to go scarf or continue to go au natural, because I've got to do a TV segment tomorrow and I'm a bit in a dilemma as to whether or not I adopt the headscarf or I just go, because it's starting to come away now a little bit more, even though my lovely oncologist was quite surprised that I still had hair. It is actually coming out. So, how are you guys? You good? I hope you're good. I have so many questions that have been sent through to me on direct message. I'm hoping that I get them all. Before I get started though, I want to draw attention to the importance of fluids after your egg collection. And the whole reason this is an issue is that I got a little bit behind on my fluid intake post chemo. And I had to have a little short admission for some rehydration therapy earlier this week. And it got me thinking about the importance of reminding anyone out there who is having an egg collection of the importance of your fluid intake after you have an egg collection. And here's the reason why. Of course, the big thing that we worry about is ovarian hyperstimulation syndrome, of course. And what happens is that each of your follicles, where the eggs are contained, produces a chemical called VEGF, V-E-G-F. And what this particular chemical does is increase the permeability of your vessels, or makes your vessels more leaky. And that means that fluid leaks out of your vessels into other spaces in your body. So, for example, into your tummy cavity, we call that ascites, into your chest cavity, which is around your lungs, or even potentially around your heart. Now, the risk that this will happen is obviously very dependent on how much VEGF is produced. And we are very worried about people who have a high amount of follicles, i.e. they're at risk of OHSS, because they're going to produce a higher amount of VEGF. But in saying that, every single follicle that you have produces VEGF. So even if you only get, half a dozen follicles, half a dozen eggs collected, or even less than that, you are still secreting VEGF, which can still make your vessels a little bit more permeable. Plus, you have fasted often leading into your egg collection, so you're dry to begin with. Plus, we give you medication that can also exacerbate you being a bit more drowsy and perhaps not drinking so much afterwards, or not even feeling like taking anything orally. So it's uber important that all of you are thinking about your fluid intake after you have had an egg collection. So when our beautiful theatre nurses turn around to you and say, please make sure that you are drinking, there is a reason why we're doing this. And it's even more important if you have risk factors for ovarian hyperstimulation syndrome to be doing exactly that. Okay, all right. So to those of you who didn't see, I'm just going to do another quickie for you. All right. So do I stay au natural without any headwear, or is it now time for me to adopt the headscarf? All right. Looking something like this. I've got a few different colors. This is just one of them. So you guys, let me know. I think you can also do these really cool kind of twists and kind of tie them, do all these really cool little twisty things. I don't know, something like that maybe. I don't know. I'm really keen for your thoughts as to, is it now time to adopt the scarf, particularly for a TV segment? Let me know what you think. Okay, on to the questions. So number one, tick, I've talked about fluid management. Somebody asked the question about sperm morphology. So sperm morphology is how the sperm looks under the microscope. And can you believe that in a normally fertile sample, 96% of sperm can look abnormal? You only need 4% to look completely normal for it to be considered a fertile sample. Morphology is a difficult measure for us. We don't really know what causes abnormal sperm morphology. So that might be if it's 3%, 2%, 1%, or none of them look normal. We don't really know. It's certainly not influenced in any way by lifestyle changes. So I know you need to tell your blokes, or maybe you're a bloke watching, to look after themselves and don't smoke and moderate alcohol intake and all of those things for quality and also concentration and motility. But morphology is not something that is changeable. So, we need to find another parameter to encourage them to adopt good lifestyle changes, but morphology is not one of those that is changeable. I'm sorry to whoever answered that question. Somebody else asked the question about spotting in the menstrual cycle. Is it normal when you're trying to conceive? And I have actually addressed this question before, because a lot of people talk about the implantation bleed and that the implantation bleed is a completely normal phenomenon. Dog barking. No, it is not. In fact, I ended up doing some reading because it's not something that is in the recent literature, but having a bleed in the luteal phase, so after you've ovulated, is not normal. You should not be bleeding, particularly when we're talking about premenstrual spotting. So that spotting that you get for days leading into the actual menstrual bleed, that is not normal. That can herald other issues. So this menstrual spotting could herald a polyp in the endometrium. It can herald endometriosis. Women with endometriosis often have an abnormal endometrium. It might be there's a fibroid in the cavity. It might be that you have a true luteal phase defect. So the progesterone is considered deficient. But do not consider that bleeding in the luteal phase in any way is normal. I would be having that investigated. Okay, that question. Somebody else asked the question about rapidly declining AMH, anti-Müllerian hormone. All right, so there are two ways that we measure the quantity of follicles as kind of a representation of the ovarian reserve. One is the AMH and the other one is the antral follicle count. So it's an ultrasound, transvaginal ultrasound picture of the ovaries where someone has physically counted the number of follicles that are of a certain size, an antral follicle size, okay? And both of these measures are considered to be good correlates of the ovarian reserve. Both of them are considered to be valuable biomarkers. I personally will use both. I'll often use them in conjunction. This particular person said they have had a rapidly declining. I don't know quite what a rapidly declining means, but if the antral follicle count itself is staying the same and there hasn't been any iatrogenic cause of decline, for example, an operation on the ovary to remove a cyst, development of an endometrioma, ovarian torsion, chemotherapy that reduces the ovarian reserve. So if there hasn't been something like that in the same period of time, I'd be more reliant on the antral follicle count. And here's the reason why. If you look at the graphs of AMH levels for different ages, it's a huge variation of what is considered to be normal or around the 50th centile. So, you might start with an AMH that is 10 and a second measure, it might come back as 6 and you think that's a rapid decline. When in fact on the graph, it might still sit within the same approximate range for a woman of that particular age. I don't believe there is great value in continuously measuring the AMH. All it's doing is creating huge anxiety. It probably doesn't change what we do from the initial treatment. we would probably be making changes to a cycle based on how you responded in the first cycle, for example. So I do think that you've got to be really mindful of just repeatedly measuring these things. And the fact of the matter is, if you're in treatment, you're in treatment. So doing an AMH is probably not necessarily going to rapidly change what we do. Probably how you respond to treatment, if you're not responding at all, is going to help us make decisions. So that's my thought on that question. Oh gosh, getting through them. Somebody else has asked a question about the impact of meditation. Does it change outcomes? Well, I suppose the first thing is you've got to think, what's the outcome you're actually measuring? So for most people in the IVF space, the outcome is, well, a live birth really, or at least a pregnancy. So does meditation change pregnancy rates or improve pregnancy rates? I do not believe that we have had a good quality randomized controlled trial looking at something like meditation. Several years ago, there was an attempt to look at the role of acupuncture, and they did real acupuncture versus sham acupuncture, and they did it in lots of different centres around Australia and New Zealand, and they found that acupuncture did not change pregnancy rates. So, however, can it change how a person perceives their treatment burden, perhaps their stress levels, whether or not they continue on with more treatment? Yes, there is certainly some anecdotal evidence, maybe even qualitative evidence that practices like meditation, acupuncture, relaxation techniques will certainly improve the patient experience, which may then mean you'll go through more treatment cycles. But as far as those hard measures that many of us are really interested in, not being done. Unlikely to be done, because it's very hard to randomize someone to meditation versus no meditation and not see the impact of the placebo, i.e. doing nothing. Sorry, my dog's barking. So would I discourage you from doing meditation? No way. I mean, take it from me, in my current experience right now, it is one thing that I am making a conscious effort to do in small doses, because I'm not very good at meditation, but I'm learning and I'm getting better. I'm not there yet, as my daughter would say. So I definitely think that there is a role for meditation in general health and well-being. And I do believe that if it's something that helps keep you in treatment to get your ultimate outcome, then do it. And in most cases, meditation is free. You know, there are so many apps online, programs that you can learn how to do this, books, audio, that you can learn how to do meditation. And I think it's certainly worth implementing. It's just your time. All right, dog. Okay, last question. And this is a biggie, so it'll be hard for me to spend too much time on when the dog stops barking. Thyroid and its impact on miscarriages. Thyroid function is incredibly important. It is a hormone, it is a gland that produces a hormone that is key in metabolism and cell development. We know that an underactive thyroid increases the risk of miscarriage. We know that underactive thyroid in the context, subclinical in the context of antithyroid antibodies, is associated with recurrent miscarriage. It is also associated with poor pregnancy outcomes. So things like preterm birth, stillbirth, growth restriction. So it is vitally important that your thyroid function is checked if you have recurrent miscarriage, and particularly your thyroid antibodies, and consideration of thyroid medication, not supplements, not bioidentical plant-based desiccated pig hormone. These things have not been validated, and we don't know if there is a degree of harm. So I would certainly recommend, in the context of miscarriage, that your thyroid function is checked. I think in the context of fertility, your thyroid function should be checked, because we know that there are autoimmune conditions such as Graves' disease, which will impact on fertility, but also impact on poor pregnancy outcomes and potentially even neonatal health. So Graves' disease is a hyperactive thyroid. Okay, whew, tick. Gosh, that was great. Were there any other questions that have popped up? I can see that a few people, hey, how you doing? Thank you, Kate and Black. I am doing all right, but yeah, just had a little hiccup with some fluid requirements. Whatever makes me comfortable. Thank you, Kate. Do you know, my mum said the same thing. She said, take a scarf and see how you feel on the day. Nikita, stylish. But, Fobella, whatever makes you feel best on the day. You sound like my mama. Au natural, how could make an outfit snazzy with a scarf? Yeah. Thanks, Joanna. That's awesome. All right. No other questions. Well, hopefully that was helpful. There were half a dozen really fantastic questions. Michelle, low progesterone. What is too low after a positive pregnancy test? Remember, Michelle, that we are measuring serum progesterone. We don't know what is happening at the level of the endometrium. And sometimes the progesterone supplementation is not measurable on the blood test. So, after a positive pregnancy test, it also depends on if it's a spontaneous pregnancy versus an IVF pregnancy. I certainly think below 30, 25, 20, I'd be really worried. And the other thing to keep in mind is what else is going on in that environment with the pregnancy. What other things are changing? What is your history been like? All of those things are super duper uber important to consider. But yes, progesterone is a hotly debated topic for us fertility specialists. Oh gosh, quick, here's one last question. Can Visan 4 years take a while to come out of your system to affect you getting pregnant? Okay, so Visan is a progestogen. It's a type of progesterone, and it can thin the endometrium, and in some cases can impact on ovulation, though it's not designed to suppress ovulation, hence why you could potentially still fall pregnant on it, because you can ovulate in the background. So if you've been on it for a long period of time, and I'm assuming it would be for endometriosis suppression, which is its whole purpose, it doesn't take long to come, Michelle, you're not a nightmare. It doesn't take long for the drug to come out of your system, but it can take some weeks for the endometrium to regrow. I have had a couple of cases, not with Visan itself, but with the combined oral contraceptive pill, where it has taken a few months for the cycle and endometrial growth to kick back in. Certainly if you're now several months down the pathway and have not had a bleed, a menstrual bleed, you should be checked to see if you're ovulatory. If you are ovulatory and not having a bleed from the endometrium, somebody should be looking at your lining for sure. Okay, Nicole, last question. Absolute last question, everyone. When is a good time to start melatonin for egg quality? Oh, it's a good one. So in my opinion, because we don't have any great evidence on this, but in my opinion, probably a good 3 months out. It's working as an antioxidant, right? That's its purpose if you're starting to improve egg quality. And you're germinating the eggs that you're eventually going to release. Probably they're being recruited a good 3 months out. So I think that if you're going to be doing it for that purpose, you should really be looking at a good 3 month process. That's balanced, of course, against you not moving through with treatment. So absolutely have a chat with your fertility specialist as to the best way to play that. Guys, I'm going to have to wrap it up. I really am. Thank you for your feedback. I really, really appreciate some feedback from you guys. It's been really great. I will see how I go tomorrow. I'll see how I go Channel 9. So if you're watching, I'll see whether I go scarf or I go au naturel. See what the hair and makeup lady thinks too. Okay, everybody, have a good rest of your week. See you soon.